we as colposcopists has faced many times confusing and frustrated moments. I too had my share, and many times my sweet score never matched histopathology findings. Many times my pap smear report or LBC report never matched my colposcopic findings. But now, as per evidence, it has been found that all this is possible, and colposcopy is a very subjective field and it is a dynamic procedure. I, Dr. Sujata Mittal, today is going to discuss about the latest evidences and how we should improve upon our colposcopy skills. First of all, first and foremost is that lot of budding gynecologists, they ask me whether colposcopy can be used as a screening tool alone. So let me tell you that colposcopy is incomplete without knowing the age, cytology, HPV status, or both of these, or separately. We should know the parity of the patient, whether she has taken prior treatment, and we should know the high risk factors, for example, multiple sexual partners, early sexual behavior, whether patient has taken the oral contraceptives or not, and whether she is having nutritional deficiencies. So, colposcopy is decision support and not a standalone test. It has been recognized that there are many cognitive errors we as colposcopists are making while doing the colposcopy. These are not taught, but they are very much responsible for making the mistakes. So, what are these biases? One is the anchoring bias, one is reassurance bias, one is fear driven conservatism, and overconfidence in the visual skill. So, I will elaborate one by one all these. First and foremost is the anchoring bias. Suppose we are doing colposcopy and we on the after application of the acetic acid, we find a dense acetovite lesion and we mentally label it as the worst lesion. So further scanning becomes cursory. So this is called the anchoring bias. This error is anchoring bias. It is not lack of the technical skill. So they say this is one of the most important biases we as colposcopists make because based on the first impression, we judge the whole cervix. So we should systematically examine the whole cervix even if we find the worst lesion. Then comes the reassurance bias. There is a high grade lesion or pap smear says or LBC says that high grade lesion is there. Lesion means high grade pap smear is there, suggestive, but we are doing colposcopy and we find the normal looking cervix. So our findings, as I just now told, that many times it has happened. So they are saying this, but patient is having the risk factors and there's a pap smear which suggests HSIL and we are finding normal cervix. Even then we have to take the biopsy and we should not reassure ourselves and the patient that everything is okay. Then there is a fear-driven conservatism among the gynecologists. Definitely, we are very much afraid of overtreatment. There's anxiety about excising CIN that might regress. We have got excessive concern about future fertility or obstetric outcomes. Then there is fear of complications like bleeding, infection, cervical stenosis, and definitely we are very much afraid of the medico-legal complications. And in such circumstances, we ask the patient to come after six months or 1 year. So what does the evidence says? That it is very dangerous because cancer progression is time dependent. CIN3 and early invasive cancer are often subtle, endocervical, and poorly acetovite. So the latest evidence is that most of the low grade, high grade lesions, they are associated with the poorly acetovite grading. So fear-driven conservatism leads to missed CIN2, delayed cancer diagnosis, and false assurance. And Ironically, this bias causes greater harm than the over-treatment it tries to avoid. So, the key teaching statement, it says, fear-driven conservatism converts uncertainty into delay, and delay is the enemy of cervical cancer prevention. So globally, if we want to eradicate cervical cancer, we need to overcome our fear. Then overconfidence in the visual skill. As we get older in doing the colposcopy, we think we are very, very uh, good masters of visual inspection after application of the acetic acid and after applications of the Lugol's iodine. But with a better understanding of the natural history and the biology of CIN and cervical cancer, it is understood that there are many hidden caveats which need to be put into attention. So now evidence is saying that we have to unlearn to learn. That is, we have to teach colposcopy in a different way. In what way? That initially, because this will be my now 11th colposcopy training program, I have conducted 10, and in each, although I know personally that colposcopy is a dynamic procedure and video colposcopy should be shown rather than the static images, but still, in case-based discussions, we have been teaching about the lesion description, we have been talking about static images and score memorization. So evidence says we should not be teaching about the lesion description, but rather the risk interpretation. That is the lesion behavior, that is speed of acetowhitening and the persistence of acetowhiteness even after 60 to 90 seconds, and vascular response to green filter. And this is based on the biology and the natural history of CIN2 and CIN3. And as I told you just now, that the colposcopy is a dynamic procedure, and we have been teaching in case-based discussions about this. On the static images, there should be abundant, because static images, they remove temporal information, they hide acetowhite evolution, they mask vascular changes. So it should be replaced with real-time video colposcopy, acetic acid application sequences, before, during, after comparison, and live case discussions. And definitely, it is not the score memorization, but we should start teaching decision thresholds, risk-based action, what to do when tests disagree, and when not to wait. So what is decision threshold? I hope every one of us is remembering that the key clinical threshold is based on the management of a patient is determined by the immediate risk of CIN3. And there are three primary decision points. If there is an immediate risk of CIN3, we have to do immediately, clinical action is to be taken. But if there is a chance of 25 to 59% development, there's a 25 to 59% chances of development of CIN3, then expedited treatment is preferred. But if the chance is less than, is between 4% to 24%, colposcopy is indicated. So this is the decision threshold. And then based on the risk the patient is having, we should take the decision. And as I was telling, there are a lot of times when our findings are not matching the test, whether histopathology or PEP or LBC report or high-risk HPV DNA report. So evidence is what we have to do in such circumstances, and in what patient we need not wait. Quite often, at least I will say that at least 90% of the 95 to 99% of the gynecologists and medical doctors, they rely a lot on guidelines. And evidence says that the guidelines underestimate cognitive load. They provide algorithms and flowcharts, but they fail to teach risk tolerance, when we should override the algorithm, and It doesn't teach how to deal with the patient pressure. The algorithms, they are for the populations and works well for most, but not all. Algorithms tell us what usually works, but we are dealing with the individualized patients. And individualized risk asks what is the safest for this particular woman. And so many times while doing the colposcopy, we have found that, as I told you earlier also, that our findings don't match the reports. And even at that point of time, guidelines fail and we get confused. So guidelines, they normally assume ideal conditions and in for the populations. Most guidelines, they assume that there will be perfect follow-up, there will be perfect compliance of the patient, we are having quality histopathology, and they will be able to provide us the medico-legal protection. But in reality, if we take our country scenario and we call a patient after 6 months, because of the fear-driven conservatism, we know very well that this patient might not come. So evidence says because of this, there's a high chances of facing high-grade disease, that is CIN2 and CIN3. And if we are doing this, then we will not be able to eradicate cervical cancer globally by 2030. So what evidence is saying that based on changes in your in the way you do the colposcopy, you treat the patient, you take the action. It says that you have to do the risk stratification, take the decision, and do the action. Guidelines, they inform, but clinical risk judgment, that decides. Okay. So while dealing with any of the patient, for every case, we should think what is the worst possible diagnosis, what is the risk of missing disease, what is the cost of overtreatment, which decision minimizes overall harm. And based on this, we should take the decision and then action. So now I'm going to come to certain parameters which evidence is saying that is going to change the practice. One is the sweet score. As I told you earlier, that we used to describe the lesions in the terms of quadrant and sharpness of the border, size of the border, size of the lesion. But in actuality, inter-observer variability is high. It is the total score which matters, and we have to teach threshold thinking, not the artistry. So instead of focusing on the exact millimeter of the lesion, border sharpness, nonsense, and color adjective, we should focus on the total score, and based on that, we should take the decision. Now, what is the score which carries the most significant meaning? That is the sweet score of 7 or high. When sweet score of 7 or high is present, there is a high probability of CIN2 and it is a decision threshold. At that point of time, we should take the decision. So this is the single most practice changing evidence, and it is not for the grading the beauty. And it has been found in the evidence that score more than 7 or equivalent to 7 has high specificity of for CIN2, that is almost 90 to 95%. And this allows see and treat, that is, it allows us to, we should take the decision at that point of time only to excise or ablate in selected patients. And this reduces the delayed treatment, loss to follow-up, and we are avoiding the multiple biopsies. Evidence is also saying that lot of gynecologists take only one biopsy, and the chances of missing CIN2 in if we take only one biopsy is up to 30 to 40%. I have personally never taken single biopsy. I always take minimum at least two. So evidence says 2 to 4 biopsies should be taken, and that increases the rate of detection of CIN2 and higher lesions. So the practice change it has brought is that always biopsy the worst area plus second suspicious quadrant. Lot of time we leave the low grade lesion, but now it is found that the low grade lesion can harbor CIN2 and CIN3. Random biopsy is indicated only if the colposcopy is inadequate or there is a cytology discordant. So, it has been found that there's a lot of sampling limitation as well as I told you just now, that low grade, we leave the low grade lesion and that is a sampling bias. So, what is the practical protocol? Take minimum 2 biopsies in suspicious cervix. Escalate your strategy when your cytology does not match your colposcopy. So, in those, we should not leave and reassure ourselves. No, the cervix is looking normal, so we should leave and we should not take the biopsy. So, what is the take-home message? Histopathology quality does not compensate for the poor sampling. Colposcopy is risk assessment and biopsy is the sampling. Okay. So based on the colposcopy, it is not necessary that even that our colposcopy findings might match the histopathology. As I told you, first time when I started doing the colposcopy, lot of times my sweet score never matches the histopathology. There might be error in taking the sample and or histopathologist himself or herself must not be so much trained to give the proper report also. So this is what the next evidence is. We have been treating histopathology as a gold standard, but it is not an absolute truth. In reality, it has been found that there's a inter-observer variation among pathologists and which is very significant. CIN2, we very well know it is a unstable as a diagnosis, and that is why special markers, IHC markers like Ki67, P53 are also used. What practice change it has brought, that you treat the biopsy, you treat the patient plus colposcopy plus cytology, not histology alone. So if there is a case of HSIL cytology plus unsatisfactory colposcopy, one should go for the diagnostic excision, especially when there is a high risk patient. That is the patient above the age of 40 and she has completed her family. Then HSIL cytology with unsatisfactory colposcopy, she should not be left and she should not be assured. We should also not assure ourselves. Rather, we should go for the diagnostic excision. Similarly, if there's a persistent cytology and there's a negative biopsy, that is, there's a disparity in the cytology and biopsy, then again you should go for the diagnostic excision. We should also understand why this evidence is coming into the why this evidence is bringing the change in the way we do the colposcopy and practice colposcopy. So actually we should understand that what we are seeing reflects what and what does it not guarantee. For example, if we see the dense acetowhite area, that means it is a surface epithelial reaction, but it will not guarantee the depth of dysplasia. Okay. Similarly, if we see the coarse mosaic, this is a type of vascular pattern because of the changes brought in the lesion because of the HPV infection, but it will not guarantee the highest grade. Similarly, sharp margins, that indicates the transformational activity, but it doesn't guarantee that this is the whole lesion, means full lesion extent. It might, lesion is a heterogeneous, lesion might be heterogeneous, means CIN is heterogeneous and it can spread on whole the cervix, not limiting to only one quadrant. So very, very important evidence is saying that we have put a lot of trust or blind trust in the low grade impression. And it is saying that up to 20% of the CIN2, they present as low grade lesion and we have missed them. This is what the evidence is saying, that we have missed lot of CIN2 and CIN3 cases, and that is why till we focus on this, cervical cancer cannot be eliminated. So what does practice change it is going to cause? That is, we should not downgrade because lesion looks mild, and biopsy what looks suspicious, not what looks severe. So this is a very important that whatever suspicious lesion you are seeing, you need to biopsy, especially in the glandular lesions also. Another very, very important area is the type of TZ3. Many times in the perimenopausal or menopausal women, I used to wonder because there's a high grade cytology, and I'm doing colposcopy only on the ectocervix. I could not see the neoscamocolumnar junction, which is inside the cervical canal. Based on the exterior colposcopy, how can we say that we will be sampling or we will be removing that particular area, including the neoscamocolumnar junction? So the evidence is saying that TZ3 significantly reduces sensitivity. And even the expert colposcopists, they miss endocervical disease in TZ3. So whenever TZ3 is there, we need to escalate, not regress. That what practice change? TZ3 plus high grade cytology, go for the diagnostic excision. Do not overtrust surface colposcopy in TZ3. Another negative colposcopy, that doesn't mean no disease. So your findings of high risk HPV DNA, positive cytology all carry the meaning. So evidence says CIN2 can exist with the normal colposcopy, minor acetovite changes, especially when your high-risk HPV DNA 16 and 18 is positive or when the glandular lesion is present. So what we should do, that we should do the cytology, and if there is a discordance in cytology and colposcopy, we should escalate, not reassure ourselves and the patient. One of the most important evidence is against the Lugol's iodine, because we have been using the Lugol's iodine test as a decisive tool. Many times, a lot of lesions we have found on the acetic acid after acetic acid application with after application of Lugol's iodine, they remain Lugol's positive and we never biopsied. And that is why there's a high chances of missing the CIN2. So evidence suggests that Lugol's has low specificity. It has got the high false positive rates. For example, it stains immature metaplasia also, inflammation also. So what practice change it is going to bring? It is says use it as an adjunct only, never override acetic acid findings or sweet score. As per guidelines, as I told you, that we doctors rely a lot on guidelines, and these in colposcopy, the guidelines, they clearly tell us to overprotect fertility in some, and they underestimate anxiety and loss to follow up in some. So fertility versus cancer risk is poorly individualized. So they say that it is a fertility versus cancer risk balancing. This leads to fear-driven conservatism, deferred diagnosis, miss CIN3 or early cancer. This can lead to miss CIN3 or early cancer. Expert says that we need to balance this because cancer risk is immediate and irreversible. Fertility risk is probabilistic and manageable. We cannot preserve fertility if we miss cancer. So, for example, in this case, I'm showing you, there's a female who is 35 years old and has completed the family with the sweet score of 8. So we should not be taking the same decision for a woman who is 22 years old, having sweet score of 8 and not completed the family or not having a single child. The same decision which we are going to take for 35-year old female will not be applicable to a 22-year-old female. In 35-year-old, we need to go for the diagnostic excision. But in 22-year-old female, not having given a single child, we need to change our decision. That is, fertility conservation is more important. And as I told, that we are very much scared of the medical legal problems. So we should train doctors to safely override guidelines when required, and these are called the gray zone colposcopy areas. So we should be teaching case-based teaching, that is, when there is a HSIL cytology plus low-grade colposcopic. So what is case-based teaching? HSIL cytology plus low-grade colposcopy. We should take the biopsy, and we should, depending on the patient's risk factor, we should go for the ablation or excision. There is a persistent symptoms with normal biopsy, we should take the decision. They are CIN2 on histology, but low clinical risk. And if there is a anxiety, poor compliance, medical legal realities, we should be, what decisions we should be taking based on the patient risk, that these are the gray zones, and we should override the guidelines in such circumstances. We are right now doing work very honestly in the terms that we explain uncertainty very honestly. We communicate watchful waiting. We document what we have told the patient and shared, and we allow in documentation the shared decision. And we are taught to handle the patient's pressure for surgery or reassurance. And this is also causing the high missing rates of CIN2. So what they are saying, that we need to develop risk explanation scripts, documentation checklist, and there should be special consent language template. And as a doctor, we should understand that when we need to override the guidelines. We need to understand that the courts do not punish deviation. They punish undocumented reasoning. So what is the defensible documentation? Document why the algorithm was overridden, not just what was done. So for example, if we write, and we have done override in one of the cases, we have overridden the guideline, then we should be writing like this. Although surveillance is an option per guideline, diagnostic excision was chosen due to persistent HPV-16, type 3 transformation zone, and inability to exclude CIN3. Fertility implication discussed and accepted. This converts deviation into expert judgment. So such templates should be developed and adhered. So again, in every female in whom we are doing colposcopy, we should answer these 4 questions. What is the worst possible diagnosis? What is the risk of missing disease? What is the harm of overtreatment? What decision minimizes the overall harm? So, friends, do the colposcopy. So, friends, do the colposcopy the way as per evidence, because we need to eliminate cervical cancer by 2020. Right now, I feel, because these evidences are coming because of high amount of missed CIN2 and CIN3 lesion. So all over the world, the colposcopists are recognized our fallacies and why we are missing the CIN2 lesion. So take care and do the colposcopy as per the latest evidences.